What is Unituxin, dinutuximab? Unituxin is a chimeric GD2 binding monoclonal antibody indicated in combination with granulocyte macrophage colony stimulating factor, GM-CSF, interleukin-2, IL-2, and 13-cis retinoic acid, RA. For the treatment of pediatric patients with high-risk neuroblastoma who achieve at least a partial response to prior first-line multi-agent, multimodality therapy. Unituxin has a boxed warning, which includes serious infusion reactions and neurotoxicity. Unituxin is contraindicated in patients with a history of anaphylaxis to Unituxin, dinutuximab. Please see important safety information at the end of this presentation, and full prescribing information, including boxed warning, available from the link below. GD2 is a disialoganglioside antigen expressed on neuroblastoma cells and on other cells of neuroectodermal origin, including the central nervous system and peripheral nerves. Targeting GD2 on tumor cells using Unituxin has become standard of care in the treatment of high-risk neuroblastoma. In a healthy person, leukocytes of the innate immune system identify and eliminate pathogens. However, in a patient with neuroblastoma, multiple mechanisms allow the neuroblastoma cells to escape immune detection and may generate a directly immunosuppressive environment. In this kind of environment, the neuroblastoma tumor is able to grow. Early studies showed that anti-GD2 monoclonal antibodies prevented neuroblastoma cells from circumventing immune defenses. How does Unituxin work? The Unituxin antibody helps the body's immune system detect neuroblastoma cells by targeting the GD2 antigen receptors and binding to them. Once bound to GD2, Unituxin triggers an immune response and induces cell lysis of neuroblastoma cells through antibody-dependent cell-mediated cytotoxicity, ADCC, and complement-dependent cytotoxicity, CDC. It is important to understand that Unituxin also targets non-cancerous cells in the body that express GD2, specifically neurons, skin melanocytes, and peripheral pain fibers. Because the GD2 antigen is expressed on some nerve cells, the binding of Unituxin can cause pain and peripheral neuropathy in patients receiving this medication. In the process of ADCC, immune cells such as natural killer NK cells and granulocytes bind to the Unituxin antibodies. This triggers the release of cytotoxins, leading to lysis of the neuroblastoma cells. Additionally, during the process of CDC, the C1 complement protein also adheres to the tumor-bound Unituxin antibodies, triggering the complement cascade. This results in the formation of the membrane attack complex, and ultimately leads to lysis of the tumor cells. Based on their ability to stimulate the body's immune system in different ways, cytokines, GM-CSF, and IL-2 were included as part of the treatment regimen with Unituxin. GM-CSF is given with Unituxin in cycles 1, 3, and 5, while IL-2 is given with Unituxin in cycles 2 and 4. GM-CSF has been shown in both in vitro and in vivo to activate monocytes, macrophages, and dendritic cells, while IL-2 has been shown to activate NK cells. RA has been shown to induce differentiation of neuroblastoma cells and is included in all 6 cycles of the antibody regimen. It is common for patients to experience side effects, some of which are serious, during Unituxin antibody treatment. Some of these side effects can be directly related to the mechanism of action of the Unituxin, while some are related to the immune response. Given these expected side effects, required pretreatment and guidelines for pain management are included in the prescribing information for Unituxin. Unituxin antibodies bind to GD2 on the surface of peripheral nerve fibers, which can result in mild to severe pain commonly experienced during and sometimes following the Unituxin infusion. Unituxin can also cause peripheral neuropathy. Severe neuropathic pain occurs in the majority of patients. Severe grade 3 peripheral sensory neuropathy ranged from 2% to 9% in patients with neuroblastoma. Therefore, aggressive pain management is essential when administering Unituxin, and a continuous opioid infusion is required. Immediately prior to initiating the Unituxin infusion, a morphine bolus dose is given, followed by a continuous morphine infusion during the administration of Unituxin. Pain may be difficult to control, and additional bolus doses as well as titration of the continuous opioid medication will likely be necessary. Consider using fentanyl or hydromorphone if morphine sulfate is not tolerated. If pain is inadequately managed with opioids, consider using gabapentin or IV lidocaine in conjunction with IV morphine. Fevers and infusion reactions are common during Unituxin antibody therapy and are likely due to immune stimulation and cytokine release. To help prevent infusion reactions and fevers, patients are given antihistamines and acetaminophen 20 minutes prior to Unituxin infusion. Antihistamines are continued throughout the infusion every 4 to 6 hours as tolerated. Acetaminophen is continued throughout the infusion every 4 to 6 hours as needed. In patients with persistent fevers or pain, consider using ibuprofen every 6 hours as needed. Immediately interrupt Unituxin for severe infusion reactions and permanently discontinue Unituxin for anaphylaxis. Immune stimulation and cytokine release may also cause endothelial damage in capillaries, which leads to increased vascular permeability and vasodilation, resulting in capillary leak syndrome. Capillary leak syndrome is characterized by intravascular fluid leakage into the interstitial space, which can lead to generalized edema and hypotension. To help maintain hydration and prevent hypotension, a sodium chloride infusion is administered over 1 hour prior to initiation of the Unituxin infusion. It is important to assess patients for signs of capillary leak syndrome by monitoring patient weight, vital signs, labs, hemoglobin, albumin, etc., and strict intake and output. Side effects may still occur even with the use of required pre-medication. The rate of the Unituxin infusion can be modified to help mitigate side effects. Unituxin can be given over 10 to 20 hours. It is not uncommon to need to slow, pause, or even stop the Unituxin infusion until side effects resolve. Please see full Unituxin prescribing information for recommendations on how to adjust the rate for specific side effects. These tables show selected adverse reactions that occurred in at least 10% of patients, and they compare all grades and grades 3 to 4 AEs in the Unituxin antibody plus RA arm with those in the RA alone arm. This table summarizes the adverse reactions that require permanent discontinuation of Unituxin. Unituxin, dinutuximab, injection for intravenous use. Indication: Unituxin is a GD2 binding monoclonal antibody indicated in combination with granulocyte macrophage colony stimulating factor, GM-CSF, interleukin-2, IL-2, and 13-cis retinoic acid, RA, for the treatment of pediatric patients with high-risk neuroblastoma who achieve at least a partial response to prior first-line multi-agent, multimodality therapy. Important safety information for Unituxin. Boxed warning. Serious infusion reactions. Serious and potentially life-threatening infusion reactions, facial and upper airway edema, dyspnea, bronchospasm, stridor, urticaria, and hypotension, occurred in 26% of patients treated with Unituxin. Administer required pre-hydration and pre-medication, including antihistamines, prior to each Unituxin infusion. Monitor patients closely for signs and symptoms of an infusion reaction during and for at least 4 hours following completion of each Unituxin infusion. Immediately interrupt Unituxin for severe infusion reactions and permanently discontinue Unituxin for anaphylaxis. Neurotoxicity. Unituxin causes serious neurologic adverse reactions, including severe neuropathic pain and peripheral neuropathy. Severe neuropathic pain occurs in the majority of patients. Administer intravenous opioid prior to, during, and for 2 hours following completion of the Unituxin infusion. Severe, grade 3, peripheral sensory neuropathy ranged from 2% to 9% in patients with neuroblastoma. In clinical studies of Unituxin and related GD2 binding antibodies, Severe motor neuropathy has occurred. Resolution of motor neuropathy did not occur in all cases. Discontinue Unituxin for severe unresponsive pain, severe sensory neuropathy, and moderate to severe peripheral motor neuropathy. Contraindications. Unituxin is contraindicated in patients with a history of anaphylaxis to dinutuximab. Warnings and precautions. Serious infusion reactions. Serious infusion reactions requiring urgent intervention including blood pressure support, bronchodilator therapy, corticosteroids, infusion rate reduction, infusion interruption, or permanent discontinuation of Unituxin included facial and upper airway edema, dyspnea, bronchospasm, stridor, urticaria, and hypotension. Infusion reactions generally occurred during or within 24 hours of completing the Unituxin infusion. Due to overlapping signs and symptoms, it was not possible to distinguish between infusion reactions and hypersensitivity reactions in some cases. Severe, grade 3 or 4 infusion reactions occurred in 35 patients, 26%, in the Unituxin 13-cis retinoic acid RA group, compared to 1 patient, 1%, receiving RA alone. Neurotoxicity, pain. 114 patients, 85%, treated in the Unituxin RA group, experienced pain despite pretreatment with analgesics including morphine sulfate infusion. Severe, grade 3 pain occurred in 68 patients, 51%, in the Unituxin RA group compared to 5 patients, 5%, in the RA group. For severe pain, decrease the Unituxin infusion rate to 0.875 milligrams per meter squared per hour. Discontinue Unituxin if pain is not adequately controlled despite infusion rate reduction and institution of maximum supportive measures. Peripheral neuropathy, severe, grade 3. Peripheral sensory neuropathy occurred in 2 patients, 1%, and severe peripheral motor neuropathy occurred in 2 patients, 1%, in the Unituxin RA group. Permanently discontinue Unituxin in patients with peripheral motor neuropathy of grade 2 or greater severity, grade 3 sensory neuropathy that interferes with daily activities for more than 2 weeks, or grade 4 sensory neuropathy. Neurological disorders of the eye. Neurological disorders of the eye experienced by 2 or more patients treated with Unituxin included blurred vision, photophobia, mydriasis, fixed or unequal pupils, optic nerve disorder, eyelid ptosis, and papilledema. Interrupt Unituxin in patients experiencing dilated pupil with sluggish light reflex or other visual disturbances that do not cause visual loss. Upon resolution, and if continued treatment with Unituxin is warranted, decrease the Unituxin dose by 50%. Permanently discontinue Unituxin in patients who experience loss of vision and in patients with recurrent eye disorder following dose reduction. Prolonged urinary retention. Urinary retention that persists for weeks to months following discontinuation of opioids has occurred in patients treated with Unituxin. Permanently discontinue Unituxin in patients with prolonged urinary retention that does not resolve with discontinuation of opioids. Transverse myelitis. Transverse myelitis has occurred in patients treated with Unituxin. Promptly evaluate any patient with signs or symptoms such as weakness, paresthesia, sensory loss, or incontinence. Permanently discontinue Unituxin in patients who develop transverse myelitis. Reversible posterior leukoencephalopathy syndrome, RPLS. RPLS has occurred in patients treated with Unituxin. Institute appropriate medical treatment and permanently discontinue Unituxin in patients with signs and symptoms of RPLS, e.g., severe headache, hypertension, visual changes, lethargy, or seizures. Capillary leak syndrome. Severe, grade 3 to 5. Capillary leak syndrome occurred in 31 patients, 23%, in the Unituxin RA group and in no patients treated with RA alone. Depending on severity, manage by immediate interruption, infusion rate reduction, or permanent discontinuation of Unituxin. Hypotension. Severe, grade 3 or 4. Hypotension occurred in 22 patients, 16%, in the Unituxin RA group compared to no patients in the RA group. Prior to each Unituxin infusion, administer required intravenous hydration. Closely monitor blood pressure during Unituxin treatment. Depending on severity, manage by immediate interruption, infusion rate reduction, or permanent discontinuation of Unituxin. Infection. Severe, grade 3 or 4. Bacteremia requiring intravenous antibiotics or other urgent intervention occurred in 17 patients, 13%, in the Unituxin RA group, compared to 5 patients, 5%, treated with RA alone. Sepsis occurred in 24 patients, 18%, in the Unituxin RA group, and in 10 patients, 9%, in the RA group. Monitor patients closely for signs and symptoms of systemic infection and temporarily discontinue Unituxin in patients who develop systemic infection until resolution of the infection. Bone marrow suppression. Severe, grade 3 or 4, thrombocytopenia, 39% versus 25%. Anemia, 34% versus 16%. Neutropenia, 34% versus 13%. And febrile neutropenia, 4% versus 0 patients. Occurred more commonly in patients in the Unituxin RA group compared to patients treated with RA alone. Monitor peripheral blood counts closely during Unituxin therapy. Electrolyte abnormalities. Severe, grade 3 or 4, hypokalemia and hyponatremia occurred in 37% and 23% of patients in the Unituxin RA group respectively, compared to 2% and 4% of patients in the RA group. Monitor serum electrolytes daily during therapy with Unituxin. Atypical hemolytic uremic syndrome. Hemolytic uremic syndrome in the absence of documented infection and resulting in renal insufficiency, electrolyte abnormalities, anemia, and hypertension occurred in 2 patients following receipt of the first cycle of Unituxin. Permanently discontinue Unituxin and institute supportive management. Embryo-fetal toxicity. Unituxin may cause fetal harm. Advise pregnant women of the potential risk to a fetus. Advise females of reproductive potential to use effective contraception during treatment and for 2 months after the last dose of Unituxin. Adverse reactions. The most common serious adverse reactions, greater than or equal to 5%, are infections, infusion reactions, hypokalemia, hypotension, pain, fever, and capillary leak syndrome. The most common adverse drug reactions, greater than or equal to 25%, in the Unituxin RA compared with RA alone, are pain, 85% versus 16%, pyrexia, 72% versus 27%, thrombocytopenia, 66% versus 43%, lymphopenia, 62% versus 36%, infusion reactions, 60% versus 9%, hypotension, 60% versus 3%, hyponatremia, 58% versus 12%, increased alanine aminotransferase, 56% versus 31%, anemia, 51% versus 22%, vomiting, 46% versus 19%, diarrhea, 43% versus 15%, hypokalemia, 43% versus 4%, capillary leak syndrome, 40% versus 1%, neutropenia, 39% versus 16%, urticaria, 37% versus 3%, hypoalbuminemia, 33% versus 3%, increased aspartate aminotransferase, 28% versus 7%, and hypocalcemia, 27% versus 0%. In post-approval use of Unituxin, the adverse reactions of prolonged urinary retention, transverse myelitis, and reversible posterior leukoencephalopathy syndrome were observed. Because these reactions are reported voluntarily from a population of uncertain size, it is not always possible to reliably estimate their frequency. Please see full prescribing information, including boxed warning for Unituxin, available from the link below.